We have already discussed a few points about the bundle branch blocks, the right bundle branch block and the left bundle branch block. We'll try to recollect them and we'll try to learn something new. So let's start with the left bundle branch block as you are familiar with this image now. In left bundle branch block, bundle is not functioning. So the impulse will travel from the AV node into the bundle of his and then to the right bundle branch. Okay. So if the impulse is coming to the right bundle branch, first of all there will be septal depolarization, and the septal depolarization will happen from right to left like this. Okay. Septal depolarization will happen first, which will happen from right to left. If it is happening from right to left in the V1, it will produce a small negative wave. It will produce a small negative wave in the V1 because it is happening in the opposite direction of that of V1. Okay, and in V6 it will produce a small positive wave. It will produce a positive wave. What happens after that? After that, there will be ventricular depolarization, right ventricle followed by left ventricle. Right ventricular depolarization, right ventricular depolarization will be shown in the V1 as a small positive wave. It will be shown as a small positive wave, and it will be followed by the left ventricular depolarization. And left ventricular depolarization is happening. It is happening through the ventricular myocytes. Left ventricular depolarization is happening through the ventricular myocytes. So it will be delayed. It will be delayed and slowed. It will be delayed and slowed. So the second wave in V1 it will be a negative wave, of course. In V1 it will be a negative wave because because the depolarization is opposite to that of V1. In case of V6, the small positive wave, initial small positive wave was because of the septal depolarization. Then there will be a slight negative wave that is because of the right ventricular depolarization, and it will be followed by the prolonged left ventricular depolarization, which will be towards the lateral leads V5, V6. So that will produce a tall positive wave. So this we have already discussed previously also. So it will produce a W pattern in V1 and M pattern in V6, and you all know the mnemonic William. W in V1, M in V6, and L for LBBB. What you need to remember is this typical morphology may not be seen in all cases. The typical morphology may not be seen in all cases. So you will get a predominant negative wave in V1, predominant positive wave in V6 with wide QRS. That may be the only manifestation of LBBB. Okay. So predominant negative in V1, predominant positive in V6, and the QRS has to be more than 120. We told you in the last lecture that QRS interval maximum QRS interval duration has to be 120 millisecond. Anything more than that is wide QRS. And wide QRS is seen in either in ventricular rhythm or supraventricular rhythm with aberrant conduction. Here there is aberrant conduction, so you are getting a wide QRS complex. This I have already told you that in the lateral lead V6, V5, V6, you will get a M pattern or a predominant positive pattern. And one more point is that there are no Q waves, absent no Q in the lateral leads. In V6, you are not getting a Q wave because Q wave was due to septal depolarization, which was happening from left to right in a normally functioning heart. Because it is happening from left to right in the V6 in the lateral leads, you are getting a small Q wave. But here in this case, because the septal depolarization happening from the right to left, you are not getting negative wave in lateral lead or V6. So absent Q. This point also we have discussed previously. So I have described it in the context of V6, but remember this is applicable to all the lateral leads. Lateral leads, we know in the precordial leads it is the V5 and V6 which are the lateral leads, and limb and augmented limb leads, it is the lead 1 and AVL which represent the lateral lead. So these findings, this M finding or the predominant positive QRS complex finding with wide QRS, you will get in all the lateral leads 1 AVL, V5 and V6. In V1, you will get a predominant negative wave, The typical W morphology may not be seen, but you will get a negative wave. This predominant negative wave can be a small r capital S RS complex, or it can be simply QS complex. QS complex means only a broad, deep negative wave. Only a broad, deep negative wave is known as the QS complex, no R wave. Okay. So this I have already told W pattern, M pattern. In V1, you will get a dominant S wave, predominant negative wave, and in V6, you will get a broad notched R wave or M shaped wave. Okay. Then coming to the diagnostic criteria, five points are there. First one is the QRS duration is more than 120 millisecond, which we have already discussed. Then dominant S in V1, both lateral leads. Lateral leads include 1 APL and V5, V6. Then absent Q in lateral leads. So all these points we have already discussed. And there is one more additional point, that is prolonged R wave time. Prolonged R wave with time is more than 60 milliseconds in lateral leads, in mostly in V5 and V6. R wave peak time. What is R wave peak time? So this is the beginning of the R wave to the maximum point of R wave, maximum amplitude of R wave. This time duration is known as the R wave peak time. Okay. So this will be delayed. This will be delayed. So R wave this is because of the ventricular depolarization, and I told ventricular depolarization will be delayed because the conduction is happening through the myocytes, at least in the left ventricle. Okay. So this will be prolonged. Okay. So these are the 5 points, and we all know how these points are derived. Go to LBBB now. We'll see some ECGs. Now again, this is the example of LBBB. You can see here there is a wide QRS complex. Wide QRS complex that is more than 3 boxes or more than 120 milliseconds. You can see there is a predominant S wave in V1, predominant R wave, monophasic R wave in V6 or lateral leads. All the lateral leads 1, VL, V5 and V6. Okay, predominant R wave. Here in V5 it is not very prominent, but in V6 you can see there is a predominant R wave and dominant S wave in V1. What else? You can see there is absence of Q wave in lateral leads. There is no Q wave in V5, V6, no Q wave in lead 1 or AVL. So all the lateral leads, they have lost the Q wave. R wave peak time is that is not very essential to demonstrate here. This is a case of LBBB, left bundle branch block. One more point I want to tell you is to look at the axis. What is the axis here? So axis here, if you see lead 1 is positive, so it is lead 1 is positive. AVF you see it is negative, so AVF it is negative. So axis is coming in this quadrant, that is left axis deviation. This is a very important point. You have to remember that all the patients, all the ECGs that have left bundle branch block will also have left axis deviation. Okay, so left axis deviation is always associated with left bundle branch block. Okay, I will see this ECG. Here also you can see, you can appreciate that there is a dominant S in V1. There is a dominant R in one lateral leads, one AVL, V5 and V6, one AVL, V5 and V6. So this is something fitting into the left bundle branch block pattern. But one very important point is here the QRS is not wide. You see here, sorry. Here the QRS is maybe some 2 small boxes. You can appreciate here also it is around 2 to 3 small boxes, between 2 to 3 small boxes. That means the QRS complex is normal or narrow. So whenever you are getting a bundle branch block pattern with normal or narrow QRS, that is known as incomplete bundle branch block. This point also I have told you previously. This is a case of incomplete LBBB, incomplete LBBB. This is incomplete LBBB. So incomplete LBBB is typical LBBB morphology with a QRS duration less than 120 milliseconds. Now coming to the right bundle branch block, we have discussed many times. Here the right bundle block. So the impulse is being conducted in the left bundle. So the septal depolarization will happen from left to right. So in V1, we will get a small positive wave first. Okay. In V6, we will get a small negative wave. Then what is happening? Then there will be a ventricular depolarization. Predominantly, first of all, it will be the left ventricle, then the right ventricular depolarization. So left ventricular depolarization will produce a negative wave in V1, maybe a small negative wave. Then the right ventricular depolarization, which will happen slowly because of the myocyte conduction, and that will produce again a positive wave in V1 because it is happening towards the V1. So this is right ventricular uh, depolarization, so that will produce a positive wave. So it will be like this. Exactly opposite will happen in V6. So this is M pattern in V1, W pattern in V6. The mnemonic must be knowing, it is narrow and RBBB. Again, you need to remember that you may not get the typical morphology. So you will get a dominant R in V1 or dominant positive wave in V1 and dominant negative wave in V6 and QRS more than 120. So this we have already discussed. This is the diagnostic criteria. It is simple. QRS more than 120. You have 3 points. Then RDS morphology V1 to V3. And wide, slurred S wave in lateral leads. Don't understand, again I will show you this. Now you can see in V1 what is happening. There is a, first of all, there is a small positive wave, so that will be R. Then there is a small negative wave, that is S. Then again there is a positive wave, that is RDS. So RDS pattern in V1. V6 what will happen? The first negative wave is because of the septal depolarization, which is happening in the opposite direction. Then there will be left ventricular depolarization, so that will produce a positive wave. Then there will be right ventricular depolarization, which will be slightly slurred and prolonged, that is because right ventricular depolarization happening through the myocyte conduction and not through the not through the bundle branch or the Purkinje fibers. So this is the wide slurred S wave in lateral leads that we'll find in right bundle branch block. Okay. If you see this ECG, you can see there is a predominant positive wave in V1, and you can appreciate the RDS pattern. Okay, RDS. So this RDS pattern is important. In case of left bundle branch block, we were using the term dominant S or dominant R, but in case of RBBB, we'll mostly use RDS pattern in V1 and a slot wide S wave in V6, as you can appreciate here. See here, again you will get RDS pattern in V1, RDS pattern in V1, and slightly slot S wave in V6. But again, something which is very interesting is QRS complex is narrow. QRS complex is narrow or normal. So this is again incomplete RBBB. Complete RBBB. What I can tell here is in contrast to left bundle branch block, right bundle branch block may not be associated with axis deviation. Okay, so isolated right bundle branch block will not cause axis deviation, but isolated left bundle branch block will cause left axis deviation. Okay, so that you have to remember. Now coming to the fascicular blocks. Okay. Fascicular, what do you mean by fascicles? Fascicles actually, the left bundle is divided into two fascicles. One is left posterior fascicle, another one is anterior fascicle. So, isolated block of these fascicles can also produce some ECG changes that we will be discussing. Now, what happens in a left anterior fascicular block? So, if this is the left anterior fascicle which is blocked, only the posterior fascicle is conducting. So, if the posterior fascicle is conducting, the initial depolarization is happening towards the inferior side, and then the entire left ventricular contraction or depolarization is happening towards the lateral side. Okay. So, in case of left anterior block, initial initial depolarization is happening towards the its inferior direction, and later depolarization is happening towards the lateral side. Towards the lateral side. Now, how this will be represented in the ECGs? So, in the inferior leads, first of all, you will get a small positive wave because the first depolarization is happening towards the inferior side, so you will get a small positive. Then you will get a large negative wave because because the net ventricular depolarization is happening towards the lateral side. So in the inferior leads, you will get something like this. This is known as smaller capital S RS pattern. Very easy to understand. Okay, because the initial depolarization is happening towards the inferior side, but the magnitude is very small. In the inferior leads, we will get a small positive wave. That is R, small r. Then the lateral depolarization, which is the predominant depolarization because of the left ventricular mass, that will produce, that is opposite of the inferior leads, so that will produce a big negative wave. So this pattern is known as RS pattern. Of course, the inferior leads you can see here 2, 3 and AVF. 2, 3 and AVF are the inferior leads. 1 AVL, V5 and V6, these are the lateral leads. Okay, 1 AVL, V5 and V6, these are the lateral leads. So what will happen in the lateral leads? In lateral leads, the first of all, because of the inferior depolarization, because of the small inferior depolarization, which is happening opposite to the reduction of the lateral leads, you will get a small negative wave. Then the predominant depolarization, which is happening towards the lateral leads, it will produce a big positive wave. So this pattern is known as small q, big R, capital R pattern. So in the inferior leads, that means in the lead 2, 3 AVF, you will get a RS pattern. In lateral leads, that is 1 AVL, V5 and V6, you will get a QR pattern. So as you can see in this ECG, you can see in the 2, 3 and AVF, you are getting a RS pattern, RS pattern, RS pattern. In the lateral leads, 1 AVL, V5 and V6. Here at least in 1 AVL, you can see there is a QR pattern. There is a QR pattern. So this is left anterior fascicular block. The outside, it is very difficult to appreciate because more or less ECG looks normal. But how will you suspect a block, a fascicular block? If you look at the axis, to try to find out the axis in this ECG, you can see the lead 1 is positive, AVF is negative. So 1 is positive, AVF is negative. So that means axis is in this quadrant, that is left axis deviation. Whenever there is a left axis deviation, you have to look for this fascicular blocks and you will get the RS in the lead 2, 3 and AVF RS complex. And in the lateral leads, we'll get the QR complex 1, AVL, V5 and V6. Here in V5 and V6, it is not very prominent. So at least in one AVL, you can see the QR complexes. Okay, so for isolated left axis deviation, left anterior fascicular block is an important cause. Okay. Exactly opposite will happen in case of left posterior fascicular block. Here, the lateral depolarization is happening first, followed by the inferior depolarization. Lateral depolarization is happening first, followed by the inferior depolarization. So exactly opposite pattern will happen in the leads. So inferior leads, now inferior leads, that means 2, 3 AVF will show the QR pattern, inferior 2, 3 and AVF, they will show the QR pattern. 1 AVL will show the RS pattern. Exactly opposite thing will happen. So I'm not going into details again. So that means what we'll get here? Here we'll get a right axis deviation because here lead 1 is negative and lead AVF is positive. So if you see uh, axis lead 1 is negative and AVF is positive, that means in this quadrant, so that is right axis deviation. So what you need to understand is left anterior fascicular block will produce left axis deviation, right anterior fascicular block will produce right axis deviation. Now what is bifascicular block? Bifascicular block means right bundle branch block plus left anterior fascicular block or right bundle branch block plus left posterior fascicular block. So bifascicular blocks have been described in the context of right bundle branch block. If right bundle branch block is associated with any of the fascicular block, that is known as the bifascicular block. Now how to identify them in ECG? Remember, anytime you see a ECG of right bundle branch block, the next step you have to do is look at the axis. Look at the axis. I told isolated right bundle branch block cannot alter the axis. So in case of right bundle branch block, if you are getting left axis deviation, that means there is associated left anterior fascicular block, and that is a case of bifascicular block. Similarly, in case of right bundle branch block, if you are getting a right axis deviation, that means it is associated with left posterior fascicular block, and combined it is known as the bifascicular block. Okay. So if you see this ECG, you can appreciate that there is RS-RDS pattern, RS-RDS pattern in V1. So this is a case of right bundle branch block. Then the next thing is you have to look at the axis. If you see axis lead 1 is positive, lead AVF is negative. 1 is positive, AVF is negative. That means it is left axis deviation. So RBBB plus left axis deviation. That means it is a bifascicular block. That is RBBB plus left anterior fascicular block. Now coming to the triphascular block. Triphascular block means RBBB. Sorry. Triphascular block means bifascicular block plus AV block, AV nodal block. The third degree AV block that is taken into consideration as a true trifascicular block, but sometimes even first degree AV block uh, is also taken as part of trifascicular block. So bifascicular block has to be there. That means you should have right bundle branch block plus some axis deviation. Either you may have a left axis deviation or you may have a right axis deviation. If you have a left axis deviation, that means left anterior fascicular block is there. If you have a right axis deviation, will have left posterior fascicular block. But along with this, you should have a AV block. Okay? AV can be first degree or third degree AV block. AV block will be discussing in that section in the subsequent ECG lectures. But just now remember it is three types: first degree, second degree, and third degree. First degree, there is just isolated prolongation of PR, just PR prolongation. In third degree, there is complete AV block, which will produce AV dissociation. AV dissociation. That means P waves will not be followed by the QRS. The atria will contract or depolarize on its own at its own rhythm, and ventricles will depolarize on their own rhythm. We will be discussing that later. It will be confusing if I tell everything now. So just remember, whenever you are getting right bundle branch block, the next step is look at the axis. If there is a axis deviation, it is bifascicular block, and the next step is you have to look for evidence of AV block. That means you look for the PR interval. You look for the PR interval. Okay, so I'll repeat again. Whenever you are getting RBBB, you should not stop there. Whenever you are finding RBBB, the next step is look at the axis. Next step is look at the axis. And if you are getting any axis deviation, the next step is you have to look for AV block. That means you look at the PR interval. Evidence of AV block, other evidence of AV block. This you have to remember. So in this ECG, you can see there is RS base pattern here. This is RBBB. Then you look at the axis. Lead 1 is positive. Lead AVF is negative. So 1 positive, AVF is negative. That means it's a left axis deviation. So plus left axis deviation. That means left anterior fascicular block. Plus, is there any evidence of AV block? Yes. So you may not be able to understand now. If you see the RR interval, if you see this 1, 2, 3, 4, 5, 6, 7, 8, 9. So what will be the heart rate? The heart rate will be around 300 divided by 9. So it will be around 33 to 34, or maybe just 33 to 35. So heart rate is around this. So this is actually a ventricular rhythm that is happening. And you can see the P waves are happening at their own pace. These are the P waves. So there is atrioventricular dissociation. This is third degree AV block actually. Third degree AV block. So that this is a trifascicular block. Okay. This is actually the true trifascicular block where you are getting a third degree AV block. But sometimes first degree AV block is also considered as trifascicular block. As in this ECG, you can see there is RBBP, right bundle branch block. Then you look at the axis. Lead 1 is positive, AVF is negative. That means left axis deviation. So bifascular block. Then you have to look at the PR interval. So if you see the PR interval here, PR interval, I have already told you, PR interval, the normal duration is 120 to 200 milliseconds. If you look at the PR interval here, that means beginning of the P to end, beginning of the P to end, beginning of the QRS complex. So here it is around 6 small boxes. That is around 240 milliseconds. So this is first degree AV block. So here you are getting right bundle branch block plus left anterior fascicular block plus first degree AV block. This is also a trifascicular block. Okay. So that's all about this blocks, bundle branch blocks and fascicular blocks. And this concept is very important to understand the further diseases also. That's all for now. Thank you everyone.